Hi guys, so today I'm going to teach you all about idiopathic intracranial hypertension. Okay, so when you see, try to understand the concept from the name itself. So here you're understanding two main concepts, that is there is increasing in the intracranial pressure. So there is increasing in ICP. Okay, and the real reason is idiopathic. What do you guys know about idiopathic? Idiopathic is nothing but the real reason is unknown. Okay, idiopathic causes unknown. So this is the both concept that you're understanding from the name itself. Okay, now we should understand how is the intracranial pressure is increasing. Before we go on into this topic, we should understand the other name for idiopathic intracranial hypertension. It is nothing other than pseudocerebral. Okay, pseudotumor cerebri. Okay, and additional things that you should all know is what I'm going to tell. We understand that there is increasing in the intracranial pressure, but always remember that there is no obvious structural changes or the finding which is noted on the imaging. What do you mean by this? As I said to you, the idiopathic intracranial hypertension is also called pseudotumor cerebri. Patient always feels that there is some tumor inside them, but there is no structural findings on the imaging. Okay, now what else if you feel? Let's first learn about the risk factor. Okay, first we are going to learn about the risk factor. Okay, next we are going to learn about the pathophysiology. This is the main two things that you should all know from this. Always remember a short form, that is FVML, like female to what? What is female to what? Female are the most common people to get affected. People who are on tetracycline, who are on tablet danlozole. Okay, so this T is covered, D is covered. So in between another two comes obesity and vitamin A in excess. Always remember, this obesity is one very important reason. Okay, so these are the risk factors. These risk factors, the action pathophysiology is to be so far as unknown. People say that there can be two reasons for the idiopathic intracranial hypertension. What are the two things? If you feel, what is the reason behind it? The reason behind it is decreased absorption, okay, and increased production of CSF. I think you guys understood. But when we go a bit more detailed, okay, we can classify it based on the vascular changes that occurs inside. The one such reason is nothing other than transverse sinus stenosis. Okay, this transverse sinus stenosis is a reason that leads to increasing in ICP. Okay, what is the reason behind it? Transverse sinus stenosis. Okay, other than that, there can be a hormonal reason. Okay, what is the hormonal reason? Aldosterone in excess, which is associated with obesity and PCOS, which affects the mineralocorticoid receptors of the choroid plexus. Okay, I think you guys understood. Aldosterone excess, which is commonly seen in obesity as well as PCOS. Okay, it affects the mineralocorticoid receptors of choroid plexus, which leads to increased CSF production. Okay, then another one reason is nothing but some cellular changes. Okay, there can be some cellular changes which causes increased outflow resistance to CSF. This can be due to estrogen or retinoic acids. These both hormones are elevated by increased adiposity on the epithelial cells, which leads to less outflow of CSF. There is nothing. There is increased in the outflow resistance to CSF, which can lead to some of the adipocytic cells increase which in turn causes increase in estrogen and retinoic acid, which causes redness outflow of the CSF because of the increased outflow resistance of CSF. I hope you understood the pathophysiology in bit detail. Okay, now what if a patient comes? How can we identify the patient? Is the very, very important things that you should know. Okay, patient will have a headache. Okay, a vision loss will be there. Okay, what else can we see in cases? Patient has pulsatile tinnitus. Okay, the patient has pulsatile tinnitus. The headache, if you see, at any locations it can be. Okay, often the headache is most commonly seen in the morning time. Okay, when it is seen, it's in the morning, or it is seen in increased manner during World Hour procedures, and this headache is associated with nausea and vomiting. Okay, then there is a transient vision loss. This is actually due to optic disc edema, which is due to temporary ischemia of optic nerve, which can lead to optic disc edema, can lead to temporary ischemia of the optic nerve. And what is this pulsatile tinnitus? This is nothing but due to transmission of the vascular pulsation by CSF. That is, when the CSF passes, okay, when the CSF passes, the venous sinuses, there is increased in pressure. Okay, because of the CSF, there is increased pressure in the venous sinuses. So this vascular pulsation because of the CSF is heard as the pulsatile tinnitus. Okay, and other than this, patient can have lots of other symptoms like diplopia. This diplopia is actually due to obtuse syndrome. Okay, but to very open, there is no change in the mental status. Okay, the impaired optic nerve axonoplasmic flow. Okay, there is some impaired optic nerve ophthalmo axonoplasmic flow, which leads to papillary edema. I will make this point more clear. Okay, what happens? Let me tell you. When there is increased intracranial pressure, okay, it compresses the nerve. What happens? It compresses the nerve. When it compresses the nerve, the axonoplasmic transport is for sure blocked, right? When it is blocked, that leads to optic disc swelling. This swelling, okay, this is actually the papillary edema. I hope you guys understand. Next, if you see, the visual field testing will show. Okay, this is history. The patient will check. So next, what you will do the visual field test, right? In the visual field test, patient will have enlarged blind spot and peripheral construction. Okay, now has decided, but she was not able to conclude what it can be. She needs to confirm this diagnosis of idiopathic intracranial hypertension. So what she does is LP. In LP, there is increased opening pressure, and when LP is done, very, very important, the patient will have temporary headache relief. I hope you understand. And the main important thing next is, you can ask me, how these diagnoses are made. So as I said, here we do LP. Next we do MRI. In MRI mostly, we can see exact diagnosis is not seen. We can see the transverse sinus stenosis, flattening of the posterior sclera, distension of the perioptic subarachnoid space, so on. Okay, and CT done if the patient is contracted. And of that examination, if you see that like internal retina, if you see those, you will see for sure the papillary edema that we told. And the diagnosis is actually made through a criteria. Okay, the criteria is known as modified Danny criteria. Modified Danny's criteria. And the treatment is very, 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 very important. First of all, give carbonic anhydrase inhibitor. Then, if not, we'll move on with a basic another in the imagination procedure, which is CSF shunt placement or optic sheath administration surgery for visual loss the patient has. This is the basic treatment. I hope you all understood. Okay, if you have any doubt, you can ask.